Alright, so last time we did a heavy revision of the histology of the entire GIT. We looked at a lot of pictures of microscopic images of different parts of the GIT, and we talked about things that are unique to different parts of the GIT, so you can really, absorb that and find those differences, so that when you're ever given a histological image of any part of the GIT, you know where it's coming from, right? So we talked about how the jejunum had the plicae circularis, where the actual submucosal stuff goes into the finger-like projections. We talked about how the ileum has the Peyer's patches, right? And we talked about the different glands and a bunch of stuff. So all of that is really significant because it can pop up. It can pop up in different ways in various questions, and you should be able to identify what you're looking at. And we left off after discussing superior mesenteric artery syndrome and nutcracker syndrome, for which we had these two pictures. And now we get to the actual arterial supply, right? So we have the abdominal aorta, we have the inferior vena cava, but more specifically for the GIT, we also have the entire portal system. So first aid itself doesn't have many images for the blood supply, but I'm going to show you a ton. I'm going to really break down the blood supply because you need to know it for the GIT really accurately. And we can dive right into that now. So first thing we have is the celiac trunk, right? And branches of the celiac trunk are these three guys. You have your common hepatic, which is right here. They're the bigger bolded ones right here, right? So you have your common hepatic, you have your celiac trunk, giving you the common hepatic, left gastric, and splenic, right? Celiac trunk, as well as the other two, are the only ones that really come out anteriorly from the aorta, and they're all guys that supply your GIT. So we're seeing the first one right now. Right, so you should know and you should be able to break down the blood supply like this, and you also should be able to draw this out, at least in your mind, right? Because you can get questions regarding this stuff. And how do you get questions about this? Well, first things first, you can see this is supplying, the celiac trunk is supplying a lot of stuff, right? It's already, from here, it's already connected to your liver, it's supplying the gallbladder. It's also, you can see in the back, it's kind of outlined right there, you have your pancreas. Right? They don't talk about the blood supply. They don't really break it down too much in first aid. But you need to understand that even your pancreas and your spleen, all of this stuff, everything in this little area is all supplied by the celiac trunk. And since it's supplying different parts of the stomach, you can see there's different little branches that supply different parts of your stomach. What can happen is if you have an ulcer in the stomach, any kind of ulcer in the stomach, that ulceration can go through the stomach and eventually cause damage to various arteries. And you can get questions on that. They could just give you a location. They'll tell you, oh, there's an ulcer at this location. What artery is in that area? And then you have to understand what artery is there. So let's really take a look at the breakdown of the blood supply. So first one here, we have your left gastric. That's the easiest one to remember. The left gastric one really just gives you the left gastric, which is going to supply this lesser curvature over here and give you a couple of esophageal branches, and that's it. So the lower end of the esophagus and this half of your small lesser curvature. All right, that's the easiest one to remember. The next one is your splenic artery, right? So you see the splenic artery going from behind the stomach. It's obviously going to supply your spleen. It also is able to give blood supply to the tail of the pancreas. All right, keep in mind from a couple pages ago, let me actually go back to that. It's hard to scroll up because there's a bunch of images in between. But right here, we saw that your splenic artery and vein and the tail of the pancreas are all in your splenorenal ligament, right? So that is where the splenic artery is able to supply the tail of the pancreas. So if you ever get a question about the blood supply of the tail of the pancreas, it's coming from the splenic artery, all right? And it's really important to remember that because a lot of students don't actually even know that, to be honest. And you can pick some other wrong answer choice in your efforts of trying to get it right. The other branches this gives you is a short gastric to the fundus of the stomach, so this upper portion of the stomach, and the left gastroepiploic. The epiploic arteries, this is your right gastroepiploic. The epiploic arteries, you could think of them as the epic arteries. They take care of the bigger curvature, the greater curvature, right? So they're your epic curvature arteries, basically. So you have this entire area now covered, right? This purple and yellow area is all covered now. So you got your left gastric and your splenic for those two guys. The blue area here, right? The blue area is all coming from the common hepatic, branches of it. So first branch of the common hepatic is your proper hepatic artery. right? This is right here, proper hepatic artery going to the liver and the gallbladder. So it gives a left hepatic, it gives a right hepatic, and then it gives a cystic artery to the gallbladder. Then your next branch is your right gastric artery, right, which just finishes up the remainder of your lesser curvature. So that's your right gastric right there. And then the last branch you have is right here from your gastroduodenal artery. Gastroduodenal artery gives two branches to cover the front and back, the anterior and posterior, superior pancreaticoduodenal, right? So it has the name pancreas in it too, because it also gives some blood supply to the head of the pancreas. And lastly, you have your right gastroepiploic, which takes care of the remainder of the greater curvature of the stomach. Right, so celiac trunk is supplying your stomach through all three different branches, supplying the spleen, supplying the liver, and supplying the proximal portion of the duodenum and the whole pancreas. Right, two different branches. The right branch over here, which is your common hepatic, takes care of the head of the pancreas. The left branch here, which is your splenic artery, takes care of the tail of the pancreas. They don't really talk much about this in first aid, but you can obviously get questions on this because all of these things are actually very high yield, right? You get many pathologies of the pancreas as well as you go on, so you really need to know the blood supply. Now, one peculiar thing is if you get an ulcer in this portion of the stomach, on the back end of the stomach, right, that ulcer can go through the back of the stomach and damage your splenic artery, which would then impede blood supply to the spleen. Right, so that's something you want to keep in mind. That's a weird kind of question you can easily get, and you might not have seen that before, so you want to remember that it is possible for an ulcer to perforate through the stomach and damage the splenic artery behind the stomach. Most commonly, though, you'll get some ulcers in this area, either on the bottom or upper area, and they'll damage your right gastric or right gastroepiploic. All right, and we're going to see what the different kind of ulcers are and how they come to be. But before we get there, you really need to make sure you understand the complete anatomy of how these organs are placed and how the blood vessels look like. So these are two different U-world pictures regarding various other questions. The questions themselves weren't the significant thing, but it's really important to grasp the correct anatomy here, right? So we can see now in this picture on the top right, we're looking at the various segments of the duodenum, right? So you have your first part, the second, the third, and then the fourth. And remember that only the second to the fourth were retroperitoneal. So they tell you here the first part of the duodenum emerges from the pylorus of the stomach and is horizontally oriented over the first lumbar vertebra. It is the only part of the duodenum that is not retroperitoneal. The second part of the duodenum courses inferiorly up from the level of L1 to L3. See, it's coming downwards. And this second part is the one that has the close relation to the head of the pancreas and contains the ampulla of Vater, the site where pancreatic and common bile duct secretions are released. So any food that only reached the first part and then got vomited will be non-bilious. But any food that has reached the second part of the duodenum and then went forward further down, that food, when you vomit it, will be bilious. And that's the real difference between any question you get, especially about infants, where the food is either with bile or not, right? That tells you where the food got impeded and then it returned. Alright, so it's really important to understand that. The third part of the duodenum courses horizontally over L3. So you see how it's just horizontal, this third part. Horizontally over L3, the abdominal aorta and the inferior vena cava. It is in close association with the uncinate process of the pancreas. Right, this little portion right here. Right, that's the uncinate process that turned around and came and got attached to the bigger part. The small bowel malignancies are rare. If they occur in the third part of the duodenum, anterior tumor invasion could compromise the superior mesenteric vessels. The fourth part of the duodenum courses superiorly and to the left of the L2 and L3 vertebra and becomes the jejunum past the ligament of Treitz. Right, so that's what's going to keep going from here. You're going to get the whole jejunum, then the ileum, and so on. And I'm going to show you another picture with that too. Here, in the picture on the left, you see more of the pancreatic anatomy. And now we could see your two kidneys as well. You could see your adrenal gland. Right, they're all at the same level. So the level of your duodenum has your kidneys and your adrenal glands, and a little above that is your spleen. All of this is in the same area. And you can see how the splenic artery is going to be the guy that's going to supply the tail of the pancreas, right? And behind the pancreas, right, this is a very important little thing to watch out for. Right behind the pancreas is where you have both your superior mesenteric artery and your portal vein. right? So pancreatitis or any tumor of the pancreas can compress any of these guys. A tumor of the pancreas can compress your superior mesenteric vessels, leading to ischemia of your intestines, of your jejunum and ileum, right? Because there won't be any blood supply to them, and then they can all just break and die off. And then if you compress your portal vein, then of course drainage isn't going to work well into the portal system, and that's going to be presenting with its own constellation of symptoms. Right, so really important to watch out for all of these little anatomical questions. Let's take a look at the ones we have here. So the first one up here, this is from Amboss. A 68-year-old man with atrial fibrillation comes to the emergency department with acute onset severe upper abdominal pain. He takes no medications. He's severely hypotensive. Despite maximal resuscitation efforts, he dies. Autopsy shows necrosis of the proximal portion of the greater curvature of the stomach, caused by an embolic occlusion of some artery. The embolus most likely passed through which of the following vessels, right? And then if you go back up here, so basically they're saying that for some reason, right, what happened to this guy? Necrosis of the proximal portion of the greater curvature of the stomach, right? So the greater curvature of the stomach is right here, right? That's entirely that yellow area, right? So if there was an embolus that stopped blood flow to this area, according to this question, then that embolus must be in your splenic artery, right? Because the splenic artery is the guy that gives the short gastric up here for the fundus, and the left gastroepiploic over here for the remainder of your greater curvature up here, the left greater curvature. And since all of that is necrosis, it must be the splenic artery, and that's the area of the stomach that's being discussed. So that was it. It was really straightforward anatomical question, but these anatomical questions become really difficult if you haven't exactly quite memorized the anatomy yet. The next question is from NBME 23. This one says a 16-year-old girl is brought to the emergency department 30 minutes after being injured in a motor vehicle accident. Her blood pressure is extremely low and physical exam shows cold, clammy skin. Chest x-ray shows a fracture of the 9th rib on the left. An exploratory operation shows a rupture of the spleen. Ligation of the blood supply to the spleen is most likely to damage which additional structures? Right? So if you ligate the blood supply to the spleen, they're basically asking you that if I stop this blood supply, then what other structures are going to be damaged? Well, obviously, you're going to be bringing lesser blood to the greater curvature, but keep in mind that all of this also has some anastomosis, so it will get some blood supply, but still, the greater curvature will have lesser blood supply. Obviously, you're not going to be bringing any blood to the spleen, but the correct answer for that question was the tail of the pancreas. Right? If you forgot that the tail of the pancreas and the splenic artery are both in your splenorenal ligament, where the tail of the pancreas is actually supplied by the splenic artery, then you wouldn't know. So of course ligation of the splenic artery will damage the tail of the pancreas because that gets blood supply from the splenic artery. Alright, so very important little anatomical stuff. And of course NBME picks on this because this isn't really discussed much either by UWorld or by First Aid itself. So really important to know that stuff. Now on the next page I have images from Amboss which show you your superior mesenteric artery and the inferior mesenteric artery. Right? The First Aid doesn't show you these guys. First Aid doesn't really go deeply into it. So this we already saw. This is the same thing. Your celiac trunk, blood supply to everything. Right? That we've gotten down. Now here we're seeing your superior mesenteric artery up here, which then comes to supply all of this. Right? So you have the ending of your ileum pretty much, right? The jejunum and ileum. So you have some jejunal arteries, you have some ileal arteries, all of that being supplied by this. The small intestine does not get any blood supply from your inferior mesenteric artery. Alright, so that's done, and then you have your ascending colon and half of your transverse colon. Right, then the latter half of your transverse colon and the descending colon all the way down to your sigmoid area is all coming from the inferior mesenteric artery. Right, so this little area right here in yellow, the cannon point, that's the place where innervation changes, right? Remember we saw earlier, let me see, I think it was right here, yeah. We saw right here when we were looking at this table in the video before this one, I told you guys that there isn't much to catch here besides the major difference in the parasympathetic innervation. Right, you can see that foregut and midgut are all supplied parasympathetic innervation from the vagus nerve, but the hindgut is all pelvic nerve. And that cannon point is exactly where that innervation changes. Right, so everything before that cannon point, all of this stuff is vagus nerve, parasympathetics. After the cannon point, all of this stuff is your pelvic splanchnic nerve for innervation. That's really important to remember that if you ever get a weird question about any of this stuff. Okay, so that's there. Now, another really good picture that Amboss provided, and you can find other images of this stuff too, is your portal system, right? So this is your entire portal, hepatic portal vein. You see this? This is the guy that's going to be draining blood and then bringing it to the liver and so on and so on. And this is your entire portal systemic blood flow, which very much kind of mimics the blood supply that we've been seeing from the celiac trunk, superior and inferior mesenteric arteries. Right, so you have your stomach over here, getting all the blood supply coming in, right, all coming in right here. You can see your same names, the gastroepiploic vein, gastric vein. There's even pancreatic veins, right, so you can see the pancreas is kind of outlined back here, right. The short gastric, all of that, all the same veins, and then esophageal veins, all that stuff coming back to the hepatic portal vein. You have your superior mesenteric vein, which also drains from the same kind of breakdown as your superior mesenteric artery was supplying, and you have your inferior mesenteric vein. Now, one cool different anatomical thing about the inferior mesenteric vein here is that the inferior mesenteric vein is actually a branch of your splenic vein. Right, so for the portal system, that is a little bit of an anatomical thing you can get a weird question on. So keep that in mind, that your inferior mesenteric vein is a branch of the splenic vein. Right, very weird that that happens. It's very different from how your inferior mesenteric artery is, which is just a branch of the aorta after the superior mesenteric. So that's something you definitely want to keep in mind as well. And what we're going to see later on is when we have various hepatic pathologies, we get disturbances in the blood flow of your hepatic portal veins. And you need to understand that when there's blood disturbance of flow in your hepatic portal vein, that flow then has to do some kind of balancing with the systemic veins of your inferior vena cava and all that. And that balanced stuff leads to issues of like vomiting blood and etc. etc. So we're going to see that. So on the next page here, we have your portosystemic anastomoses, right? So you can see the dark blue right here is your portal venous system. The lighter blue is your systemic venous system. So you can see your inferior vena cava, right? All the green arrows are showing you normal venous drainage. Right, so you have your three areas. Number one is the esophagus, which normally drains into your azygos vein. Number two is your umbilicus, which normally drains into the epigastric veins over here, going into the inferior vena cava eventually. And then number three is the anus, which drains into your various middle and inferior rectal veins. Okay, so those are all your normal guys. Now, what is the point of this anastomosis? So if there's ever an issue in the portal vein for whatever reason whatsoever, you can get pathological blood flow because of portal hypertension, right? And that pathological blood flow is the red arrows. So you can see now you have blood coming down to the umbilicus in your paraumbilical vein, and that's going to be the one that you're going to see in number two. In number one, you have blood coming from your left gastric vein into the esophagus area, right? So that's how you get your esophageal varices. And then the last one here, this one you're seeing your inferior mesenteric vein, which is a branch of your splenic vein. Inferior mesenteric vein bringing blood down to the superior rectal vein, leading to varices over here. Right? So three different pathological blood flows that you have to know very well. You got to know the names of the veins, where they come from, and what they do. Right? And that's what we're seeing right here. So site of anastomosis and clinical sign. Right, so if you look at it, the esophagus, you start seeing esophageal varices in a patient with portal hypertension, and then you're going to have shunting of blood from the portal to systemic, and the portal blood was your left gastric, giving it to your azygos vein. That leads to your esophageal varices. That's how you get that. You can get questions directly on this stuff. You can get a question about a guy presenting with esophageal varices, and then they ask you what vein is bringing the blood to there, so the answer would be left gastric. Or who is it being brought into? It's being brought into the azygos vein. The other one, then you have your caput medusae, right, in the umbilical area, and that occurs because of paraumbilical veins from the portal system, bringing blood into your small epigastric veins, right? Epigastric veins are very important, so was the epigastric artery. We talked about how the epigastric guys are the only vessels that actually kind of come out and go upwards, right? Most vessels that branch out of any major artery or vein kind of really go downwards or stay horizontal, and very few or none really travel upwards, but the epigastric ones, they do, epigastric veins and arteries. The last thing in the rectum, right, you can get anorectal varices or worsening of any hemorrhoids that the patient might already have, and that is between the portal superior rectal vein, also known as the superior hemorrhoidal vein, right? That is a portal system vein coming from the inferior mesenteric vein. That is bringing blood down into the anal rectal area and messing up the blood flow that was originally coming from the middle and inferior rectal veins. Right? So really important to watch out for this kind of stuff. You can get very specific questions just about those guys. So how do you fix this? Treatment is with a transjugular intrahepatic portosystemic shunt, also known as TIPS, between the portal vein and the hepatic vein. So if you combine the portal and hepatic vein, you end up combining portal blood flow and your systemic circulation, right? And once you do that, you kind of lower the blood pressure and stuff. The only thing that can possibly happen in a patient who just got a TIPS is hepatic encephalopathy, right? And we've discussed hepatic encephalopathy in pretty good depth when we were in our biochemistry section, and then we're going to see it again later on under neurology as well, right? So hepatic encephalopathy with the asterixis and all the ammonium and all that stuff. Really important to go back and check that if you've forgotten about it. And I have two questions down here too now. So first one, they're both from UWorld. First one says, 46-year-old man is brought to the emergency department by paramedics after an episode of large volume hematemesis. He was going over some papers at work when he suddenly felt nauseous and started vomiting up bright red blood. Physical exam reveals a palpable spleen. Endoscopy shows bleeding esophageal varices. A liver biopsy shows no abnormalities. What is the most likely cause of his condition? So they gave you a lot of information. They didn't even need to give you a liver biopsy shows no abnormalities, but they did. They really wanted to help you be able to learn the differences between these various answer choices. So most people got it right. Most people got both of these questions right, actually. But the reason I put them here is because they highlight a very interesting clinical picture in the question stem itself, and they teach a good lesson. So the correct answer for this guy was portal vein thrombosis, which is what's being shown in the image right here. So this guy has a portal vein thrombosis. For some reason, there's blood coagulation right here, and there was a thrombosis right here. So that was the correct answer, 57%. 13% chose long-term alcohol consumption, and 24% chose Budd-Chiari syndrome, which we haven't seen yet. This patient is exhibiting signs of portal hypertension, including esophageal varices and splenic enlargement. Varices form in portal hypertension due to increased hydrostatic pressure in the portal system that causes blood to be shunted through portal caval anastomosis. This patient's normal liver biopsy indicates a pre-sinusoidal process is responsible for the portal hypertension. Pre-sinusoidal means that the liver itself is not the culprit here, right? And his liver biopsy being normal means that there's no cirrhosis occurring, nothing is wrong with it. There's no inflammation, so it's not hepatitis either. Portal vein thrombosis causes obstruction in portal venous flow upstream from the liver, causing portal hypertension while leaving the liver unaffected. Ascites is uncommon with portal vein thrombosis since sinusoidal hypertension does not back up. Right? Ascites occurs when there's something with sinusoidal involvement, and we're going to see that in the next picture, in the next image, the next question. But this patient didn't have any ascites. They didn't talk about it. This patient had this issue, right? Portal vein thrombosis, so you can see all the blood is now starting to back up. Right? So he's got the esophageal varices, he's got the splenic enlargement, and he's going to have coughing up blood, and that's what he did. He vomited bright red blood. This next question is related to the stuff we just talked about above. So a 52-year-old man, and notice how this question is different from the clinical picture in the previous question. 52-year-old man is brought to the emergency department again for hematemesis that began an hour earlier. He has regularly consumed large amounts of alcohol for the past 20 years, and he has been hospitalized numerous times due to ethanol intoxication. Temperature is 98F, blood pressure is 90/60, pulse is 106, and respiratory rate is 22. Physical exam shows jaundice and scleral icterus. Exam of the abdomen reveals a palpable spleen and moderate ascites. So he has ascites. When you see that, that means that the sinusoids of the liver are involved, and it's not just about the portal hypertension. Endoscopy reveals bleeding esophageal varices. His condition most likely resulted from chronic shunting of blood through what veins? And the answer for this one was left gastric. Right? He has esophageal varices, and that comes because of the left gastric. Right? The left gastric one right here, you see it too. Left gastric shunting to the azygos vein, and that's what's happening right here. Esophageal varices in this guy. But this guy, he's an alcoholic, so his liver is actually messed up. He's going to eventually get liver cirrhosis and stuff like that. And we're going to see more of that as we go on. But it's really important to start really grasping and understanding this difference in the clinical pictures between both of these patients, right? Very similar. I mean, the main thing they're coming for is very similar. They're both coughing, or not coughing, sorry. They're both vomiting blood, right? They're both vomiting blood. The hematemesis they're both having is their primary issue. But the root cause of the hematemesis is very different for both patients. The next page brings up another really high-yield topic, which is your pectinate line. Right, so the pectinate line, above the pectinate line is the internal stuff, and the below the pectinate line is everything that's external, everything outside. And this pectinate line really decides whether or not hemorrhoids that the patient gets are going to be painful or not. So obviously anything internal will not be painful, and you have to remember that. Just keep in mind you can't really feel something that is kind of touching you on the inner ends in some sort of painful way, right? The only abdominal pain we really get is when there's actual bleeding. But other than that, if you have like something in your small intestine and it's kind of like touching the small intestine like that or whatever, you can't really sense that, right? There's no feeling in that aspect over there. So you really need to memorize and perfectly know the nerve, arterial, venous, and lymphatic supply of both the above portion and the below portion. Fortunately, everything is actually pretty straightforward, and it's not all over the place. So nervous supply of the of the internal area is what I'm going to call it, or above the pectinate line, is from the visceral innervation. So that visceral innervation is actually your autonomic nerves, which come from the inferior hypogastric plexus. And that's really easy to remember because it's hypogastric, it's below your stomach, right? Hypogastric plexus. But nerve supply of the external area below the pectinate line comes from somatic innervation. And somatic stuff, which is pretty much your skin, is pain sensing, right? You can sense pain on your body. So obviously any external hemorrhoids are going to be painful, right? Somatic innervation is from the pudendal nerve. See, this one right here, this nerve that they're showing you would be your inferior rectal nerve from the pudendal nerve, right? Then you go to arterial supply. So above the arterial supply is superior rectal artery, which comes from the inferior mesenteric artery. You would also have your middle rectal artery here, which comes from the internal iliac. So keep that in mind. Very important to remember that. Right, this is your, you can see the middle rectal vein and inferior rectal vein. They don't come from the same place, right? Your superior rectal vein, this one up here, superior rectal vein came from your inferior mesenteric vein. The arterial supply is very similar as well. As you see, your superior rectal artery came from your inferior mesenteric artery. That's it. Only the superior guy, though. The inferior one, and I think I have another picture. Yeah, there's other pictures down here. Yeah, just these guys. So this is anorectal venous drainage, and this is an amboss picture showing you the other arteries and veins. I'll come back to that. Let's do this one first. So down here, for the external area, below the pectinate line, the arterial supply is again pudendal, right? So the pudendal artery is a branch of your internal artery, and this picture here is just your inferior rectal artery, right? In fact, everything below, everything external is actually pudendal, so that's what's nice about that. Really easy to remember. Everything above is superior rectal, right? So you can see the venous drainage is superior rectal vein going to the inferior mesenteric vein, which is a branch of your splenic vein, and that ultimately leads to your portal vein. So I keep stressing that, right? Inferior mesenteric vein is a branch of your splenic vein. You have to remember that. You can actually get answer choices that are flows like this, right? And it might be missing something, so it has to flow correctly, and you have to make sure you know that flow. The lymphatic drainage internally is internal iliac lymphatic nodes. So really easy to know that too. Internal, right? So this internal area is all internal iliac. Outside, this is outside. This is external, so that's superficial inguinal nodes, all right? The venous drainage, inferior rectal, goes again to internal pudendal, which ultimately goes to internal iliac, finally coming back to the inferior vena cava, right? Very different stuff. So this portion here, since it goes to the portal vein, your internal area of the above the pectinal line is still considered part of your GIT because it's draining back to the portal vein, right? Draining back to the portal vein. You can give injections of medications and stuff here for it to be drained into the portal vein and ultimately come back to the liver. It's really important to keep that stuff in mind. But external area, after the pectinate line, it's all no longer GIT. So this is just skin here now. This is just your normal, any part of your body's skin. Alright, so you feel pain and it all goes to your systemic blood supply. Now one pathological thing they mention here is an anal fissure, right? A tear in the anal mucosa below the pectinate line, so right here. Pain while pooping, blood on toilet paper, located posteriorly because this area is poorly perfused, associated with low fiber diets and constipation and also obesity. Keep that in mind, right? Really obese patients are also going to have even lesser blood supply to this area below the pectinate line, which further predisposes them to getting anal fissures. And anal fissures are pretty common. It's not the rarest thing on earth. A lot of people have asymptomatic anal fissures, where the anal fissure isn't exactly causing major symptoms yet, but it can get worse or it can get better depending on the patient's lifestyle and what they do about it. So this up here is a question from UWorld about anal fissures. So you can see it says, a 40-year-old man presents with pain on defecation. The pain is sharp and severe, but subsides within minutes of passing the bowel movement. So if we stop right here, first thing I'm noticing is he has pain on defecation, which means if he's sensing anything, it must be external, right? It must be after the pectinate line. So something is wrong after the pectinate line, because he would not feel pain on defecation if something was only wrong in the internal area, because this area is all visceral nervous supply. It doesn't feel pain, okay? Then they go on to tell you he notes that he often sees spots of bright red blood on the toilet paper. Rectal exam reveals a tear of the anal mucosa. Such tears are most commonly found at where? And the correct answer was the posterior midline distal to the dentate line, right? After the dentate line, obviously. Oh, keep in mind the pectinal line is also called the dentate line, right? They tell you, dentate line. Two different names, which I've always really despised, and I've mentioned this before in my videos, that the purpose of a name is to have one, right? Once you start giving things multiple names, does it really serve a purpose to have a name anymore? Because that's not how I think names work. But it is what it is. So pectinate line, dentate line, same thing. So posterior midline, distal to the dentate line. Other answer choices were like anterior midline or proximal to the dentate line, etc., etc. Those were all wrong. Majority of people did get this correct. He probably has an anal fissure, a longitudinal tear in the mucosa of the distal anal canal. Majority of fissures, more than 90%, occur at the posterior midline of the anal verge because this area is relatively poorly perfused. So it is a sensitive area to trauma by hard fecal mass. Anal fissures are associated with constipation and low fiber diets, which low fiber diets would make your fecal masses really hard. Chronic anal fissures may be accompanied by spasms of the internal anal sphincter, causing enlarged anal skin tag distal to the fissure. Right, so it can really mess up a lot of things. You definitely need to go get that checked, and you need to change your diet. So down here now, this image on the left is showing your anal rectal venous drainage, which we just saw. Right, so you can see this blue area right here is the superior rectal vein going to the portal system. Right, that's the superior stuff. So this is going to go to your superior rectal vein, which is going to go direct to the portal system. Then here, you can see you have your internal iliac vein, which is part of your systemic blood supply, right? It's draining from the inferior rectal vein as well as your middle rectal vein, right? All coming into your internal iliac, right? The inferior rectal vein first goes to the internal pudendal, though, right? Internal pudendal is very important. Pudendal in general is very important for everything below here, Okay, so this is one picture of it. When we go up here, the picture we saw, this is another one, right? Superior rectal vein. Remember which superior rectal vein was? Yeah, the superior rectal vein was a branch of your inferior mesenteric vein, and the inferior mesenteric vein is a branch of your splenic vein. Okay, so don't mess that up. Superior rectal vein goes to your splenic vein through the inferior mesenteric. Right? This picture is a little more intimidating looking, but it's generally just showing you that the pectinate line is right here. You can see there's a lot of blood supply right at that area, right? Really coiled up veins, and you can get hemorrhoids above or below based off of where the pressure is. Okay, lymphatic. You can see the nervous supply up here, inferior hypogastric plexus, which is what I just showed you guys up here too. Right, so this thing here was your inferior hypogastric plexus, so that's what's being shown for the upper area, the internal area. Below, though, outside, we have your inferior rectal nerve, which is going to go to your pudendal nerve. Right? Same thing for your blood supply, inferior rectal artery, inferior rectal vein, all the same stuff. So this is a really nice image, very high definition, if anything, but it breaks it down for you really well. Right? At the top, I mentioned something about fecal incontinence, which does not have its own section in first aid. But I put it here because I felt like it fit, right? Because all the other information about pooping is pretty much right here. So fecal incontinence is it's also a pretty high yield topic, but not as high yield as urinary incontinence is. You definitely need to know urinary incontinence inside out really, really well. But fecal incontinence is something you should understand too. So sympathetic fibers from the superior rectal and hypogastric plexuses stimulate and maintain the internal anal sphincter contraction. Remember, sympathetic is for fight or flight. You can't be pooping when you're ready to fight. So when you have sympathetic activity, it actually closes, it contracts your anal sphincter, the internal one, and you will not be passing any feces. Its contraction is inhibited by the parasympathetic fiber, which is for rest and digest. So you will be passing feces when you have parasympathetic stimulation. This sphincter is tonically contracted most of the time to prevent any leakage of fluid or gas, but it is relaxed upon distension of the rectal ampulla, requiring voluntary contraction of the puborectalis and external anal sphincter. Right, those are the ones that are under your control, so that even if you really, really need to poop, you can hold it in by using your external anal sphincter. The pudendal nerve, which carries somatic fibers, motor and sensory, provides the innervation to the external anal sphincter. Right? And that's what we have out here, the pudendal nerve. Okay. So that's pretty much the breakdown of everything for this page. At the bottom, we have one more question before we break into liver tissue architecture. So this question is actually going to be a pretty nice revision of things we've seen already when we started gastrointestinal in the beginning. So a 3-day-old girl is brought to the emergency department by her parents due to persistent vomiting and refusal to feed. Right, so you have a 3-day-old girl. So this is pretty much a baby that just took birth. The vomiting began early in the morning and has been greenish yellow color. So that's meconium right there. The emesis does not contain blood. Her heart rate is 175 and blood pressure is within normal limits. After initial evaluation is complete, the infant undergoes laparotomy. Findings include a normal appearing duodenum, the absence of a large segment of jejunum and ileum, and the remainder of the distal ileum winding around a thin vascular stalk. Not thin, sorry. What intrauterine process is most likely responsible for her condition? So she has jejunal and ileal atresia, right? And earlier in embryology of GIT, we talked about duodenal atresia versus jejunal and ileal atresia and how they're both different in radiographic findings about them and stuff like that. So this patient's issue is obviously going to be due to vascular occlusion, which only 28% of people chose. 32% of people chose abnormal rotation, and 21% chose recanalization failure. So here we have 3 different answer choices, which you should know what is each one of those answer choices correct for. This patient has jejunal atresia, not malrotation or duodenal atresia. That's what those 2 other answer choices are for. So bilious emesis in a neonate is a sign of intestinal obstruction below the second part of the duodenum. The differential diagnosis includes midgut volvulus, which is a surgical emergency and must be excluded definitively. Other causes include intestinal stenosis and atresia. The more distal the atresia, the more likely it is to present with abdominal distension rather than bilious emesis. The absence of a segment of jejunum and ileum in this case, confirms that the infant's condition is due to intestinal atresia, which is usually due to vascular occlusion in utero. Diminished intestinal perfusion leads to ischemia of a segment of bowel with subsequent stenosis or atresia of the lumen. If a major vessel is occluded, such as celiac, superior mesenteric, or inferior mesenteric artery, then the area of intestinal necrosis is large. The distal segment of the ileum assumes a spiral configuration around an ileocolic vessel. This is the apple peel or Christmas tree deformity that we would see under radiographic imaging. Abdominal malrotation can lead to amygdala volvulus, but her findings of atresia rather than malrotation ruled this out. That's why 32% were wrong by picking abnormal rotation. Recanalization failure, which the other 21% chose, is related to duodenal atresia, which this patient did not have. All right, and over here when they say the more distal the atresia, the more likely it is to present with abdominal distension rather than bilious emesis. That's really important too. So what they're saying is, if the atresia, so let's go back to a better image. Let me see. Okay, so if the atresia was all the way at the end, like only over here, then food would make it to here, and that's why you would have abdominal distension, right? It's not going to make it here and go back up. But if your atresia is much more proximal, way in the beginning of the small intestine, right after the duodenum, then yes, food can go back up the duodenum, and then you do end up vomiting it, okay? So that's what they mean. So if you have a baby that's coming in with intestinal atresia and there's only, all you see is abdominal extension, but you don't see bilious vomiting, that means that it's a very distal atresia, maybe near the end of the ileum somewhere. So food reached that area and now it's stuck there, and you have abdominal distension only in such a patient. All right. So very important little differences between all of that, and really important to grasp that well. Let me see now. Okay. The remainder of this is going to be pretty much your liver and the MDs don't lie stuff coming from the inguinal area. So I'll do that in the next video. I'm going to be right back and we'll continue on from there. Thanks a lot for joining, guys.